And I think it's an appropriate question in the sense that we're trying to first do no harm. And I think we've got to use all the evidence out there to do what's best for our patients.
Welcome to In Service, the EMS podcast, where frontline experience meets leadership insight. Hosted by Jason Falvey, a seasoned paramedic and EMS leader with over 30 years in the field. This show brings you conversations with people shaping emergency medical services today. From street-level medics to innovators on the bleeding edge of EMS, we dive into real stories, leadership strategies, and what it takes to build high-performing teams in high-stakes environments. Let's get in service.
We copy you down, Eagle. Tranquility Base here. The Eagle has landed.
Today we're joined by Dr. George Malcom III. He is an emergency department medical director at a trauma center in Metropolitan Atlanta. Dr. Malcom is a board-certified emergency physician whose career spans frontline care and leadership. As a medical director, he's led teams through high-acuity cardiac, stroke, and trauma care, and he was formally recognized as a Medical Director of the Year. Beyond the title, Dr. Malcom is known for calm leadership, clear communication, and a relentless focus on rapid, coordinated care. Welcome, Dr. Malcom. All right, good morning. Welcome, Dr. Malcom.
Thank you. Thank you for letting me come.
Thanks for coming in here this morning. It's not too early, but early enough.
That's right.
Yeah. So tell us a little about where you grew up, where you're from.
So I am from the Atlanta area, and my dad is an emergency room doctor, so I got exposed to EMS early and was in the military for about 5 years and went back, took a few classes, and ended up going to med school at the Medical College of Georgia and went to residency at Wake Forest University, Baptist Medical Center up there in Winston-Salem, and came back to the Atlanta area to practice medicine.
Wow, that's fantastic. Now, I heard you went to West Point. Is that true?
That is true.
How many buttons are on the long gray coat?
Oh, gosh. I don't think that was something we had to memorize. we had to know how many gallons of water in Lusk Reservoir, but there are a lot of buttons. Thinking about the some of those coats have not changed in like 100 years is pretty crazy.
Yeah. What's your current role today?
So I am a medical director in an emergency department in a level 2 trauma center, and I'm a medical director for a fire department and medical director for an EMS company.
Awesome.
So, and those roles all kind of they work, they synergize, they work together. So it's not, sometimes I do something for one and it actually takes care of all three. So that's a nice perk of the way those roles fit together.
Yeah, and you get to see our people coming in there all the time, so
that's
you see exactly what they're doing. I did bring you a gift here this morning. It's a box of meat. That's how we say welcome.
Yes.
It's from Waleska Cattle Company.
Thank you.
Yeah.
Thank you very much.
Hope you enjoy that.
I will put it to use.
What do you see is the biggest challenges in the ED when receiving patients from EMS?
So I had a doctor who's practiced emergency medicine for a long time, and he told me the one case that he was litigated against was when he really didn't listen closely to the EMS crew. And so I've always taken that to heart. Now that I work closely with EMS, I'm partial to EMS, but I think it's just getting a good history and making sure we have time to talk to EMS. They have spent and will spend more time with a patient than I will.
And they have the advantage of having seen the environment they came out of, which could be
And really,
helpful.
that's so important. And really, my first question to EMS, I mean, assuming somebody's stable and doesn't need to be intubated in the next minute, is where are you coming from? What's this person's normal state? That's my first question. Are they coming from memory care? Is this somebody who's usually up and, lives by themselves, takes care of all their stuff. So that history, but I just really need to talk to that crew, and then the crew knowing what's important. I mean, they don't realize that the history is everything. And if they walk out of there and don't have the medicines, then I don't know if I can give TPA or not, or TNK. If I need to know, is the family coming? And I've got probably more questions than nursing. So I try to get in and talk to the crew, but things are busy. I can't always get in there right away. I might not be able to get there. And so that's a challenge.
And we had talked last week about a patient. A crew had brought a patient in. They had him on, I think, 3 liters of oxygen via nasal cannula. And it never got communicated to you why they're actually on the oxygen, because they're normally not on it. And it seems like such a small thing, but it does affect how you're going to care for the patient.
Correct. Because, people will see somebody, their SAT will go down to 90 momentarily, possibly, and then they put them on oxygen. And I need to know, I mean, do they really, really need oxygen? Maybe they're, that's
could have been a comfort measure.
Could have been a comfort measure. Could have been, sometimes patients will ask for oxygen because they think they need it, but they really don't. And so that kind of information is critical. Yeah, just getting the right story, especially nursing home patients. Why did they come? Who sent them here? Did they really want something else looked at? Was it simply because they had a fall and the rules say you have to come? Does family want them here? Did family resist bringing them here? Because there's so many of those, that nuance that affects how much or how little I do and what I think the patient needs. So yeah, it's just, and making sure the crew doesn't run out before I have time to get over to the patient.
That's good. Yeah, that's excellent. How much information are you looking for, right? When the crew is transporting the patient and they call the ER to give an inbound report, how much information are they looking for? Obviously, it's going to be based on the acuity of the patient, but on the low end and on the high end, what do you see that as?
I don't think we need to spend a lot of time on the phone. I think we can get a lot of information. Sick patient, not very sick, needs an alert team. Is it a stroke that needs a stroke alert? Is it a cardiac patient that potentially needs the cath team? Is it a trauma team that needs? And so I think that's up to the crews to know what's criteria does their hospital use. And I'll just take trauma. I mean, and I need to know that there's some key factors that do play a role. How high did they fall from? How fast were they going? If it's MVA, and then what are their injuries and what are their vital signs? And those vital signs are key. And I hope that they're taking good vital signs and not just because, I mean, waking up a trauma surgeon at night and bringing in the team is the difference between 10 millimeters of mercury on their systolic blood pressure.
Right.
And so I hope they give, but I don't really think there needs to be a lot of, if we know what to say, we can limit, but I don't think anybody wants to be on that radio very long.
Right. Do you see it more as conversational versus just a static report? Because I think you can get a lot out of that, right?
Right. I think what I don't like to see is you lose the benefit of the conversational is hopefully you can tell me what's really going on. That this is a very bad car accident and people are really hurt and I'm bringing you a really sick patient. Sometimes if you just give a simple static, the vital signs, it can be helpful. If I have a good blood pressure, that can tell me that's one of the more common indicators for activating certain alerts. And but if they can't see the big picture for this static report, then you lose the benefit of the short report. So I guess it's a combination, and I try to make feel comfortable enough to try to, if they don't feel confident with their medical ease that they can just get across what's going on comfortably. Because they probably know, and just getting that information across.
Yeah. And you've come to know the EMTs and paramedics, so you have confidence there that you're going to take what they're saying.
Correct. And look, everybody's pushing us to do it too. I mean, the cath team doesn't want to get a bad number because we didn't trust the EMS crew. They want to get a heads up, and that 5 minutes that they have extra time to drive in can be the difference between meeting some of their metrics, which ultimately help patients.
Right. Let's shift over and talk about what's a no-go. How do you decide which procedures or medications a paramedic can perform in the field under your medical direction? So when you're choosing or updating protocols, what are the decision points there?
Yeah. I think that's a question, and I think it's an appropriate question in the sense that we're trying to first do no harm. And I think we've got to use all the evidence out there to do what's best for our patients. And I know sometimes it's not as big of a topic lately, but the whole intubation thing is we're in a more of a metro area. There's not as long of transport times. And I think the data has shown that the iGel and some of these airways can be better. It can help patients arrive safely to the ER. So I think you've got to really look at the skill of your crews and your practice environment, and then just look at the cost of some of these things. And you got to weigh it all, and hopefully at the end you're doing what's best for your patients, your patient population.
Because, it comes up in conversation here quite a bit, especially with crews, about RSI or blood products or even cardizem, bringing it into the field. And we can take a look at that. Merritt Reiner was on an earlier podcast, and there are so many different areas he will look into to make those determinations. And just particularly with blood products, what's our TXA usage, right? How many of those patients within 30 minutes of getting to the ER actually got blood? And those are huge indicators.
Correct, because the one thing that's nice about TXA is you would figure if you're going to get blood products, you should get TXA. And if we're not using TXA, then how much blood are we really going to use? And the thing about TXA is it's kind of cheap. And so we can roll that out and get some data for later, because I know blood has been is a hot topic, and it's shown some benefits in some smaller or in certain systems. But yeah, that's the kind of homework that and research that we need to do because giving blood is an expensive proposition, and you want to make sure it's going to have the effect and your resources are best used with that.
Right. We know that the ET tube is the gold standard. You mentioned a minute ago managing airways. What's your thoughts on when a crew should pull an iGel or a supraglottic airway in place in ET tube?
I think you got to think about the distance. How long are we going to be doing this using an iGel? And how's the patient doing with their iGel? And what do they think the odds are of success? I mean, if you have somebody who, based on the criteria we're all taught about the thyromental distance and things like this, if this looks like a really difficult intubation, boy, that would definitely sway me one way, versus this is, looks like, an easy person to intubate. So I think you got to weigh all of that, because when you intubate somebody and they're not getting bagged or they're not getting their CPR, if that's it going on, I mean, it's a difficult procedure, and things happen.
And those are important considerations, right? You're going to stop CPR to go into that airway. You have to pre-oxygenate before you get in there.
Right.
And if you can't get that tube and you're taking 2-3 attempts, what are we really doing now? What are we ignoring?
Right.
In favor of doing this?
Right. What could we be doing better, such as really good CPR or good ventilation that they're not getting. Whereas when you get to that hospital, you've got a controlled environment. So that would definitely make it easier to get that airway. But those are definitely, you got to just think about all of that.
Yeah. It's a challenge.
Yeah.
Let's talk a little bit about mental health crisis, right? I want to hear your view of capacity, right? Because that's really what it comes down to in the end when we make that decision to take somebody.
So I would say that that's what I get called about the most.
And it's it's a good percentage of the calls we're running every day are mental health crisis calls.
Right. And so there's always, EMS crews are concerned, hey, am I going to get accused of kidnapping? Is family not going to be happy with this? And I think you've got to think about what you're going to put in your report, your trip report. I mean, your PCR's got to show why you did what you did, and capacity. People are here in Georgia, killing yourself is not a crime, and that's kind of different than some states. However, if you're confused, if you're sick and you're not thinking rationally, then we have a responsibility to bring those patients in. So you've got to think about things. You've got to document why you think they're not capable, or don't have capacity. Do they appear sick? Do they appear mentally ill? Do they appear psychotic and truly just not able to communicate with you? If they can't tell you what they're thinking, maybe, well, then you have to assume the worst. And I use that a lot, because if somebody's not talking to you, then you got to assume they don't know what they're thinking. And that is the biggest issue going on right now. And just going over that again and again with crews, and to look at the situation and use some common sense. I think a lot of times you know the right answer, but but you're just not sure you can prove it. But you have time later to think about and to document why you made that decision.
Is the person not answering my questions because they're just annoyed we're here? Right. Or is it they're not able to?
They really can't communicate because they're not thinking rationally and clearly. And I also say this too, is get, when you have those patients, when possible, get as much help as you can. Get family there. I mean, get family to help you. Get police to help you. They might not do all your work for you, but they can at least give you support. And you might have to explain to police what you're doing and why you're doing, because police might say, well, they haven't broken the law. And it's like, yes, but they don't have capacity, and I'm concerned they could hurt themselves or others. So yeah, get support. Which I'm going to go off on a little limb here, talk about something else. I see one of the problems in emergency care today is everybody's busy, and we're used to calling for medical control and getting a lot of help. I see ER doctors not being trained as much on how to help EMS, not understanding exactly what EMS is trying to do, not understanding, just not understanding. So I push for the crews to really think about when they need to call. There are times to call, but anytime you can make your own decision and not call, because it's going to take time, can be valuable time that you could be getting that patient in a truck, getting them moved, and they're going to have to locate a doctor. It's going to take a long time to explain to the doctor what's going on. Is the doctor really going to understand? So yeah, I try to make my protocols give the paramedic a lot of leeway in what they have to call about, because I like them to make their own decisions in the field.
Yeah. As long as they're acting in the best interest of the patient, right?
Right. Yeah. It's all comes down to that. I mean, you're doing what you're trying to, that's the guiding principle. And it's so true. I mean, if you're doing what you think is best, I don't think it, and I would, you can even put that into your PCR at whatever level. I felt this patient was in danger. I didn't feel like they could take care of this, took them to the hospital for this reason. And when you explain that and write it down. Just don't think many people are going to fault you.
Yeah, that's a good piece of advice right there. How about partner agencies, right? We have a lot of partner agencies we work with, and they have sometimes different protocols or even different medical directors. And it can be a friction point when making care decisions or even opposing care directives.
Yeah.
What are your thoughts on that?
I know around here in the Atlanta area, we have some systems set up so that we can collaborate with them. That's helpful. And then it comes down to interpersonal skills. Hopefully you can work with them on scene and do what's best. I think knowing
it's not a competition. It's just care for the patient.
That's right. Right. You got to put the ego down and try to work and just being supportive of people, like recognizing when someone might need help and asking for help. I seem to see more cases of crews saying they don't need a ride along from a fire department or something. And then they get into some trouble. And I don't know why you would turn down free help.
Right. If they're offering to ride in with you, they may see something you're not seeing.
Right. And because you never know how much experience somebody has, or maybe they had a patient recently that deteriorated, decompensated, and it's not right there in your immediate differential.
And also, if they're offering to ride along, it's a whole process for them, right? They have to send somebody to retrieve them from the hot. They're not just throwing that out there because they may see something you're not seeing, and maybe getting in the back of that ambulance, closing the doors and transporting, they'll communicate what that is, because the scene might not allow them to
do that. And sometimes, you don't have time to kind of it.
Yeah. What are some of the most common clinical issues or errors that you see in the ED when EMS brings somebody in? How do you address that with them?
I think
and maybe error isn't the right word.
Right. It's so that's one thing I love about my role, is that being in a hospital where paramedics that I know come, and we all know our paramedics, even if you're not their medical director, you can give advice. I think not recognizing the patient that's about to code, pretty sick. Yeah, but I think that's the mistakes that, the fact that you thought they broke their left arm and it's actually their right knee that's broken. I mean, you got them there, you told us, but the mistakes that matter are the patients that are compensating and are fixing to fall off the cliff, and you don't see it coming.
They're not recognizing.
They don't recognize that sometimes. And you've got to be pushy and say that this patient has been working hard for a long time now. They need help. Now, I mean, 99 times out of 100, we're recognizing it. But there are those cases, and it's rare, but those are the cases that matter. Those are the ones everybody talks about. So just being able to speak up for a patient before they're that sick, sometimes it takes some courage to go to a charge nurse or somebody and say, hey, I know this patient appears to have stable vital signs and just a little tachycardic, but this has been going on a while and I'm very concerned about them. Just that gestalt to say, I'm very concerned about them.
Yeah. That's good.
Yeah. Yeah. To have that courage. Then a lot of times, one thing I think is kind of funny, and I'll just bring this up, is EKGs. So a lot of times crews will ask me, well, what could I have done better? And I'm thinking, I don't see anything you could have done better. And they'll ask about an EKG or something. And I know I'll look at the EKG and not really be sure. And then I'll show a cardiologist, and well, they're not exactly sure what it was either. So don't always think there's a specific right answer to every EKG. And I've seen us give the wrong medicine and it did the right thing in clinical practice. So yeah, it's hard. It's hard out there. But I respect the crews that ask for feedback. And I think asking for feedback is good because if I do have something to say, it gives me that opportunity to say it. Might not be, it's more rare, but when I do have something, I can show you, yeah, here's where we went wrong. Whereas I might not just voluntarily come out and say, oh, you were off by a little bit on this. But so, yeah, it's nice when they ask.
Yeah.
Gives me that a way to share. Yeah.
How do you feel about joint training between our field crews and some of the ER staff? Do you think that could be beneficial?
I definitely think it can be beneficial. Definitely think, and I'm very happy when some of our stroke team will go out and come and give a class to the crews because they really key in on what information is needed. And it seems like we say it and then it still doesn't get done. So the more times they can hear it is so important. And then, just going over certain key issues like, hey, we're having trouble getting the EKGs transmitted. When you're talking to these people, all of a sudden, a lot of these problems get ironed out a little better.
Mm-hmm.
And so, because stroke still so important, what medicines are they on? When was the last known well? Not when did symptoms start? When's the last known well? And things like that are just so important and need to be. And when you hear it from the teams that take care of the patient, very important.
Yeah. Any particular innovations in emergency medicine right now that are exciting you or that you're excited about?
I think it's crazy as it may sound, it's a buzzword and everybody's talking about AI, but AI is changing things. I can go and quickly get specific answers to questions. What drug would be best for this particular rhythm and this patient, and is this contraindicated? So some of that's helping. Yes. And I think the opportunity for paramedics to get some outside learning is like even through things like this podcast. Just when I interview all our paramedics and I ask them what kind of outside learning do they learn? Because, hey, once you're through passing your test, you might have to recertify on certain things, but a little bit of a weekly learning goes a lot more than cramming for a week for a test. And so, yeah, I think that's.
Yeah. And one small piece of information you pick up, even from a podcast like this, you might apply that 3 years down the road and make a difference.
Oh, right. Yeah. Just, yeah.
Yeah. Let's talk about overcrowding in the ER, right? And
Right.
that affects us and it affects the crews when they're holding the wall there waiting for a bed to open up.
Yeah.
And that kind of falls on you guys, unfortunately, or the hospital, right?
Right. And I feel responsible. It's like I feel bad, and it's not my fault. It's what I want to say sometimes. And when you come up with these makeshift solutions of putting having one crew stay and take care of 3 or 4 patients and all this, but it's stressful and it's scary. It's scary because their patients. It's not a good thing.
Yeah. And COVID was really the big challenge there, right?
Right.
Everybody was jammed up. It was funny from our perspective, our call volume during COVID was cut in half. And the number of patients we were actually transplanting was so small, but still we had that problem on the other end, right?
Yeah.
It just weren't enough beds.
Yeah. That's crazy. Looking back, I wish I could go back now, and it's kind of running together for me. I wish I could really see the numbers and see what happened and see some of that.
It definitely changed a lot of things for us. What leadership lessons have you learned as a medical director being in the ER? You think that could apply, right?
Yeah, I think the main thing is first of all, people want to do the right thing. People want to learn. You need a system. You need a system to catch the bad cases, the cases that we could have done better on. That's really the biggest thing. And just to me, being available to talk to crews is fun and easy, and you like things that are fun and easy. And I think giving people feedback, establishing those relationships and seeing the relationships go on. But having having some kind of system for, whatever you want to call it, peer review or case review.
Interpersonal relationships you mentioned a minute ago.
Right.
I think those are the most important things we have in our life. In a work setting, in EMS, it just makes the care so much better when everybody is able to, when you roll up to a scene and you know the person there, you really know them, and you can gauge from them how bad this patient is or not. Or,
Right.
Right? Yeah, I think it's really good.
Yep. Yeah, no, for sure.
How do you think your role is going to evolve over the next 10 years as a medical director?
Wow, that's a interesting question. I think I'm going to have to be technically savvy, whatever it is. I think, I like the interpersonal part, comes natural to me.
And let me just say, you are so well respected and loved by our crews. I've never heard anything to the contrary of that.
Well, thank you. And I think, and I enjoy that opportunity to, I think EMS does have I don't know, it's I hate to say thankless job. That's not right. We all have tough jobs, but it's such a fun thing to be able to be on the other side and to offer some of that. So that's fun. That for me is what I enjoy. But I think with just all the new products that are coming out, the cost can potentially rise. With new, fun, great products, there can be good products, but look, there's only so much money out there. How do you decide what's best? And, keeping people engaged to stay on top of all this.
Yeah.
I
just read an article 2 days ago about drones, right? They're deploying drones now with AEDs to remote areas. They can beat the ambulance there.
I know.
In rural communities, they're using them now, not just on the law enforcement side of it. There's so many benefits there, but down in Texas, they're using them to get to a scene of a car accident. And AI is able to tell you through the drone how many patients are involved, how bad the wreck is. It can estimate speeds of the vehicles prior to the crash based on skid marks. That's powerful information, right?
That is. That's
Imagine if you're a trauma surgeon or you could see that footage.
Yeah. Well, to be honest,
before the crew even gets there, right?
Now of course, I'm afraid that'll mess me up because, when a patient arrives and they don't look too bad, then they show me a picture of the car and I'm like, oh, man, if I'd seen that picture of the car, I would have ordered more tests. So I don't know if that's going to be helpful or not. Because it's amazing how good these cars are these days. That thing crumples around them and that the passenger compartment just stays protected.
60 miles an hour, the transmission and engine drop away from the vehicle to preserve the safety cage.
I know.
Some of the technology there.
I know.
Amazing.
Yeah.
And I got started in EMS before airbags came out. So we used to see heads going through windshields all the time if they weren't seatbelted. You'd see that. And the first time I went to a crash with an airbag, the guy had no injuries. The other person punched his head through the windshield.
Yeah.
Night and day. It's fascinating. What piece of advice would you give to a new paramedic who's just getting out in the field? He's going to be nervous about talking to you, or she.
Right. So they're in an exciting field. I want them to know they're in an exciting field where they can really be on cutting edge technology, medical stuff. So that's cool. You're in a neat field. You're doing a lot of neat stuff, and give it time and learn what you can from other people and just talk. And that's my big thing is try to use what's out there. Use podcasts. Use just read up what you can, and publications, periodicals. If you can go to certain society things like NAEMS,
trade shows,
types of stuff. Yeah, go into that to jump all in, and that would serve you well.
Yeah. Listen, thank you so much coming in today. I know you ran out of the ER to come over here to do this. That's fantastic.
I learned a lot. Just talking about stuff it's kind of motivating for me also.
Yeah.
Actually.
I appreciate you very much. Again, you're widely respected and greatly loved by our crews, and
I want to keep that up.
I see why. Yeah.
Cool.
Thank you.
Thank you, Jason.
Thank you for listening to In Service, the EMS podcast, where frontline experience meets leadership insight. If you have found value in this conversation, please like, subscribe, share, and leave a comment. You will find links in the episode notes.